Welcome back to Caffeinated Chest Cases. My name is Dr. Sekai, and today I'm bringing you two cases, both of which involve anatomical variations. Here's a 68-year-old female who underwent a chest radiograph prior to a knee replacement surgery. I'm going to give you a couple of seconds so that you can take a look at the image on your own, and hopefully we can all agree that the aortic knob and the stripe of the descending aorta are both visible on the right hand side, meaning we're looking at a case of a right aortic arch. The right aortic arch has several subtypes, out of which type 1 and type 2 are the most important for us. Type 1 is the so-called mirror image type, and this is actually a case of that. And type 2 is a right aortic arch with an aberrant subclavian artery. For now, let's take a look at the CT images so that we can better understand what the type 1 means. Here I'm showing you the coronal and the axial contrast-enhanced CT slices. Let's find the left ventricle, and here you can see the ascending aorta, and the first branch of the aorta is actually the common trunk of the left common carotid artery and the left subclavian arteries, which is very similar to what you would expect to see under normal conditions, but on the right hand side. So I guess from now on, it's no surprise that the next two branches are going to be the right common carotid and the right subclavian arteries, but these originate individually from the aorta as you would expect to see them under normal conditions, but on the left hand side. Also note that the vertebral artery on the right originates from the aortic arch instead of the subclavian artery, which I guess is an anomaly within an anomaly in itself. So that makes this case even extra special. Our next case is about the most common congenital abnormality of the thoracic venous system with an approximate prevalence of 0.5%. Take a look at this image and tell me what you see. You can see that this patient has a pacemaker with two leads. The leads were inserted through the subclavian vein, but instead of crossing over to the right hand side, the leads pass downwards next to the aortic knob, and through the heart's shadow, they reach their final destination, which is the right atrium. You might ask yourself, how could that be? Well, it turns out that this patient has a persistent left superior vena cava and a right superior vena cava. But that's only obvious if we open the CT. Unfortunately, I only have a non-enhanced chest CT of this patient, but I think it's going to be plenty for you to understand the anatomy in this case. Let's find the superior vena cava on the right hand side and follow it down towards the heart. You can see that it's quite thin, but it accepts the azygous vein, and together they enter the right atrium. And now if we go back to the lung apex and follow the pacemaker leads, you can see that there actually is a left superior vena cava, which passes next to the aortic knob, the left pulmonary artery, and finally it enters the coronary sinus and terminates in the right atrium. Sometimes the left superior vena cava terminates in the left atrium, resulting in a right to left shunt. And sometimes there's also a bridging vein between the right and the left superior vena cava. But in this case, there is no bridging an innominate vein. And that's that. I hope you like this case, and I hope to see you back next time on another episode of Caffeinated Chest Cases. Goodbye.